Hi, I'm Christie Ballantyne. I'm the Chief of Cardiology and Cardiovascular Research at Baylor College of Medicine and one of the co-chairs of the Cardiometabolic Health Congress.
My name is Amit Khera. I'm a cardiologist and faculty member of the Center for Genomic Medicine at Massachusetts General Hospital in Boston.
Well, Amit, you've been doing some really exciting work in the area of genomics and taking that to not only cardiovascular but cardiometabolic problems. So maybe you could share some of the key points for our audience in terms of what you've shown and where we're going.
Yeah, thanks so much, Christy. And I think we're at a really important tipping point where all the work we've been doing and the research that we've been doing in genomics has really now the opportunity to start to impact what we do in our clinical practice. So let me give you a couple examples. One is that we've known for 100 years that family history increases risk for heart attack. We never had the tools to really look at the precise molecular underpinnings until the last few years. So you've led many pioneering studies for familial hypercholesterolemia. It turns out that about 1 in 200 people actually have a very high risk mutation that prevents them from clearing cholesterol in their body, and that triples or quadruples their risk for a heart attack. So one important effort is to find and help those people. But we've actually been interested in an additional question, which is what can we actually say about the remaining 99.5% of the population?
So I think, and this is what's, we've always, people say, well, cardiovascular disease, it's an example. We know there's a very large environmental component and that it's polygenic. And so it's a difficult disease to study. So that brings us to the next thing is, well, yeah, it's polygenic, and so monogenic traits, it's important to find those individuals, and there's a lot of things happening in that area, but also there is a hereditary component. We know it's polygenic, so you've made some big advances in this area of, well, how do we get our arms around the, quantitative assessment of polygenic risk?
That's right. And so, and to define the term polygenic is really thinking not about one site in DNA variation that quadruples your risk, but how does actually the many millions of different variants that differ from between me and you, how might I take that information, combine all that into one number? And that number should be an inherited susceptibility for heart attack. So we actually have been able to take advantage of better data and better algorithms that are now available and have developed actually a polygenic score that looks at 6 million places in your DNA and gives you a number that's in a perfectly normal bell-shaped distribution, some people high and some people low. Now this number you can obtain from the time of birth. And what's really interesting is that the people who are on the high end of that distribution, say the top 8% of the distribution, they're at triple the normal risk for heart attack, actually risk equivalent of familial hypercholesterolemia. Even more important, we can't pick them out by things like LDL cholesterol, and so they're slightly more common that they have family history and high blood pressure and so forth, as you would expect, but these individuals are really flying under the radar within our current clinical practice.
So you've done this for cardiovascular disease, but you can also develop polygenic risk scores for other things, so that are related to cardiometabolic problems, right?
That's exactly right. And so what I'm most excited about is how generalizable this approach has been. So we've done about 10 different diseases. I'll give you one example which is related to obesity actually. And what we were able to show is that individuals who are severely obese in our society, it's not that environment is not important, it's very important. But the vast majority of them actually inherited a very strong genetic predisposition. And so they really in some sense had the deck stacked against them from the time they were born. And we were able to show that for any given physical activity and healthy lifestyle, they were still much more likely. So they had to work much more hard to overcome their genetic susceptibility.
So now in terms of the informatics, the genetic variants that are predisposing to atherosclerotic cardiovascular disease are not going to be the same ones for obesity necessarily, right? You're having different models to...
Exactly. So in this case, actually, obesity does predispose to heart attack, right. So there is a correlation, meaning right. They're somewhat loosely associated, but we really had the best luck in defining specific scores for
obesity versus...
Exactly.
Yes.
And it really lays the foundation for, from the time of birth, getting a whole polygenic susceptibility panel for 3, 5, 10 important diseases that you could then use to help empower patients. How can you overcome whatever susceptibility they have?
So there's, it's been interesting because I've also do a lot with epidemiologists and clinicians, and so the people come back, well, this is polygenic risk scores are not going to be as strong of a predictor as a coronary calcium score. But you pointed out just then is that, remember, we get a coronary calcium score much later in life, so it's usually over the age of 40. So that's a lot. If you're talking about obesity and what's, with this epidemic of obesity and diabetes, that's too late. Mm-hmm. So I think that a lot of the issues that we have in the area of prevention is we do too little, too late.
Right.
And what you're talking about is a tool that would allow us to really make this issue of, your child at increased risk, really, at birth, that there may be strategies relating to lifestyle that could be beneficial.
That's right. And it not only is present from the time of birth, but the impact can actually emerge very early. So as an example, we actually looked at newborns who were followed for 18 years in the United Kingdom with respect to their score for obesity. Now, obesity score actually had no impact on their birth weight. But what was really interesting is we said, well, when does that gradient start to emerge? And it turned out that we really saw a clear pattern starting around 3 to 4 years of age when people are really just entering preschool. And by the time people were entering young adulthood at 18, there was a very strong gradient, like a 20 or 30 pound gradient based on where you were in that obesity distribution.
Right. So I'm the enthusiast, having done a postdoc in genetics many years ago, and my first grant got sent in. They say, why is a cardiology fellow in a genetics lab working on ICAM1, which is an adhesion molecule? So we've come a long ways in there, but to me, I see there could be an opportunity. And Val Fuster's done some very nice work in this, where if you work at the level of both the parents and the child, which Europe would be able to do now with this genetic, that we might make a bigger impact with lifestyle modification, particularly in things like obesity in terms of education, diet, and exercise. Any thoughts on kind of targeting the family with this?
That's right. I think that's definitely a beneficial approach. The more you can get, we know this excellent data from smoking cessation, where if your partner quits, you're much more likely to quit. I think the same is likely to be true for adherence to medicines or some of these other interventions.
Well, that takes us lots of exciting potential. Now the next step is, how do we actually test this in trials, but also what about in clinical practice? What's going on? What are you up to there?
Yeah, so at least at our own hospital, Mass General Hospital, we really recognize the future where genomics could be kind of routine clinical practice. So we actually just launched this month a preventive genomics clinic. And so we've embedded ourselves with a team of genetic counselors, research coordinators, laboratory geneticists within a primary care at Mass General. And our goal is really to say, well, if a patient has a familial hypercholesterolemia mutation, but they're healthy, or a mature onset diabetes young mutation, but they're healthy, we want to have them come in and before they get disease, empower them to overcome that. Similarly, many of our clinicians really aren't comfortable with the vast array of genetic testing that's available. So we're a resource either by an e-consult, they can send us an e-consult about their patient, or we're happy to see their patient as well, and really help navigate what are the expectations for genetic testing, which testing might be appropriate, and if we order it, then to help integrate that into their downstream management. And last, I'll just make a point. This isn't our goal, but if you're ever in town in Boston and you just want state-of-the-art genome interpretation, we think it's important that we're able to offer that as well.
So it's a very exciting time. We're doing something similar at Baylor College of Medicine. We're in our cardiology group. We're doing a pilot of 1,000 patients, and they're getting sequencing of 158 genes known to be whether you have pathogenic variants causing cardiovascular disease, along with the polygenic risk score, pharmacogenomics, we're in the middle now. It's exciting times. A lot of challenges though in terms of how do we get our colleagues to understand this data, how to act upon that data. The educational barriers, and then also the patient information. So, and I know you're working in all these areas, so it's going to be an exciting time. I think in the next 5 to 10 years, we'll see a big impact in our practices. Any last comments?
I think you're exactly right. I mean, this is the new area in terms of approach of disclosing patients. Make sure doctors understand it, make sure patients understand it. I'm excited to actually, do pilot studies at Texas and Massachusetts and come together in meetings like the Cardiometabolic Health Congress to exchange ideas, what works and what didn't, because it's going to take a team effort to get us there.
And it's definitely a team effort, as you said. Even doing this, we have ethicists, geneticists, cardiologists. it's just in terms of the informatics people, it's really a team science. Very exciting. Amit Khera, great update in terms of where we are now and where we're going. Thank you so much.
Thank you.